Welcome, myself Dr. Roshini, your OBGYN faculty at DigiNerve. So now again we are going to do a quick revision for our INI-CET exam. I know you are very well tense now, but be calm and composed. Quick revision of your MCQs and high yield topics is the key for your exam. So let us quickly begin for the revision of today's class, that is your postmenopausal bleeding and endometrial CA. A brief conversation on this so that you can revise what you have learnt. So to begin with, what is postmenopausal bleeding? Yes, first of all, postmenopausal is more than 1 year of menopause, isn't it? After cessation of menstruation, normally menstruating women will stop her menstruation at least for 1 year or 12 months. Then only you consider it as postmenopausal period. So after the 12 months, anytime if she starts bleeding, then it is a case of postmenopausal bleeding. Okay, since postmenopausal bleeding is very high relation with endometrial CA, it is really very much significant to diagnose it in the early stages. Okay, perimenopausal AUB is very common and postmenopausal bleeding is not common and it should never happen, and if it is happening then you should evaluate. But still, in benign cause, the most common cause will be senile endometritis. Okay, senile endometritis is the commonest cause for postmenopausal bleeding, but remember, you should always rule out endometrial CA. Okay, without ruling out endometrial CA, you cannot conclude it as senile endometritis. Okay, if it is just one episode and after your investigation everything is normal, then you can reassure her for sure, but still investigating her is most important. So coming to the causes, vulval like injuries can happen. Since she's a old patient now, she might have injuries or vulval hematomas, trauma, or warts and infections. Vagina, again, senile vaginitis is very common. Okay, dry vagina and senile vaginitis because of lack of estrogen postmenopausally. Then cervix, polyps, cervical polyps, or erosions or cervical injuries also are common. Coming to uterus, this we discussed in AUB, common causes for the bleeding in any patient, be it premenstrual or postmenstrual. Coming to fallopian tube, malignancies can cause postmenopausal bleeding. Even ovarian malignancies or theca lutein tumors can cause. Coming to urinary tract lesions, again cystitis or chronic that bleeding she might misjudge as vaginal bleeding or caruncles can be there, then it can cause. Coming to the bowels, okay, hemorrhoids are commonly mistaken, then they come usually to us, then saying complaints. Per rectal is confused as per vaginal bleeding. Then tamoxifen, if anybody is on for breast CA on tamoxifen, yes, they also can have a bleeding following endometrial hyperplasia because of tamoxifen. This will cause endometrial hyperplasia, so that is why they also can give. So if the uterus is there and patient is receiving tamoxifen, then compensation with progesterone should always be added for such patients. Coming to investigations, so investing a case of postmenopausal bleeding is must. Okay, leave all your CBC and sugar since she's old patient, and other investigation RFT LFT, which is common to her, will be your pap smear to know the cervical cause. Then you will do a ultrasound. This is the most important of all. What is the important information that you have to get from ultrasound will be your endometrial thickness. Okay, as an intern or many times you would have they would have told you go get her ET done, scan done, let me know her ET from the scanning room, things like that, isn't it? So her ET, endometrial thickness, is very important. If it is less than 4 mm, then you can reassure the patient. If it is more than 4 mm, then you'll have to further investigate her by doing a endometrial sampling. Okay, endometrial sampling, and the best or the ideal or gold standard for this is hysteroscopic guided. So if maybe at a particular region the endometrial thickness is high, when you're doing an endometrial sample you miss that location, then you'll miss the lesion, isn't it? So that is why hysteroscopic guided endometrial biopsy is the gold standard of investigation in a case of postmenopausal bleeding. So this is how will you investigate her. Coming to the management, it depends on the type. Okay, for example, if it is less than 4 mm, you will reassure. Usually it is senile endometritis, and then you can reassure the patient and tell nothing much to worry, and then you should, if there is one more bout, then she can return to you, or you, if she is anxious, you can do a simple hysterectomy also. And if it is more than 4 mm, then you will have to do a endometrial sampling, and that says atypia or without atypia, then your treatment depends on that. If it is without atypia, then it is not a malignancy. You can put LNG IUS, or you can do a simple hysterectomy if patient is wanting. Best option would be your LNG IUS without atypia. Okay, this may be your question. Without atypia, LNG IUS is the best mode of management for her. If she is anxious or very keen on getting her uterus removed, then only hysterectomy has to be performed if patient is very anxious about endometrial CA. No, if there is no anxious, then you can just put a LNG IUS. Then coming to with atypia, then that will become your endometrial CA. Okay, so here we are dealing with so now after this, now let us go ahead with endometrial carcinoma. So this is how the carcinoma lesions look like. They may give you photos, so and so patient operated and it look like this. So this is your endometrial CA. You can see full thickness involvement of the lesion. So coming to the risk factors are very common for endometrial CA. Long-term unopposed estrogen, be it obesity, be it tamoxifen, growth, HRT, wherever they have given long-term unopposed estrogen. Familial Lynch-2 syndrome, or your estrogen producing tumors like in ovarian tumors, and higher income and educated status. Higher the income and education, fat content of food is high, isn't it? That such people have very high tendency. Older age group, especially postmenopausal age group. Nulliparity and white race. Also menstrual irregularity. Previously they had menstrual irregularity, infertility, then late menopause, early menarche, tamoxifen, obesity, type 2 diabetes, hypertension and thyroid. Type 2 diabetes mellitus, hypertension and obesity. These three, okay. Hypertension, obesity and type 2 diabetes mellitus, having a postmenopausal bleeding, then very high chance of having a endometrial CA. This is called your corpus cancer syndrome, okay. Next, going ahead with the types. So this is the latest classification where you have to know the types, that is type 1 and 2. 1 is mostly estrogen dependent tumor, which is more common and comprised of 90%, usually well differentiated and good prognosis. Okay, since it is estrogen dependent. In such tumors, you can even give hormonal therapy for treatment. Okay, so type 2 is estrogen independent, develops atrophic endometrium, mostly undifferentiated and poor prognosis. Histologically, these tumors may have papillary, serous or clear cell variety, p53 mutation seen. Early metastasis may metastasize to omentum, lymph node and other structures. Coming to the pathological types, histologically, endometrioid kind of adenocarcinoma, adenosquamous carcinoma, papillary serous carcinoma. These are the common classification, clear cell carcinoma. Coming to diagnosis of endometrial CA, this also is just same as your postmenopausal bleeding. Remember, for endometrial CA, pap smear has 50% sensitivity only. Okay, best method would be your hysteroscopic guided endometrial biopsy. Okay, hysteroscopic guided endometrial biopsy will only confirm a endometrial CA. This is your tissue biopsy confirmation. After that, maybe to know the staging and diagnosis further, you can do metastasis, you can do MRI, CT or PET CT scan to know the pickup, or even in the lymph nodes or any other metastasis structures. Then coming to the staging. So the FIGO 2009, stage 1 is tumor confined to corpus uteri, that is 1A, 1B, which is less than half of myometrium, and invasion equal or more than half of myometrium. Stage 2 is cervical stroma and does not extend beyond the uterus. And coming to stage 3, local or regional spread. Stage 3A is tumor invades the serosa corpus, and B is vaginal involvement or parametrial involvement. C is metastasis to pelvic lymph node and para-aortic lymph node. C1 is pelvic and C2 is para-aortic. Coming to stage 4, it is the same. Local invasion, bladder and bowel will be 4A, and distant metastasis with intra-abdominal metastasis or inguinal metastasis will be stage 4B. So this is only 2009. So the newer upgradation will be either G1, G2, G3. This is what is G1 is glandular pattern maintained. Then cells shows atypia. Okay, if the glandular pattern is maintained, then it is a G1. G2 is your showing papillary pattern and are solid. G3 is your glands are solid and glandular architecture is lost. Cellular proliferation is still present. Coming to the treatment, you can choose for surgical, radiotherapy or chemotherapy, combined therapy or hormonal therapy. Okay, surgery is usually for 1A only, usually not beyond that. So 1A G1. Okay, your glandular hyperplasia, this a globular one without atypia or with minimal atypia, then it is surgery only. If it is A with G2 and G3, then you can go for vaginal brachytherapy. If it is B with G1 and G2, vaginal brachytherapy, and B with G3, then you go for surgery with brachytherapy and external pelvic radiation. Let me clear all this field for you so that you can take a picture of this and remember in your exam clearly. I do not want to mark on this. Stage 3 is for surgery and external radiotherapy and vaginal brachytherapy. 3 is for surgery with external radiotherapy, brachytherapy and chemotherapy. 4 is for palliative radiotherapy and chemotherapy and progesterones. Remember, hormone sensitive, then you can give even your hormones for treatment of choice. Coming to how we prevent a case of endometrial CA. So, adding progesterones for 12 days in HRT reduces the risk by 2%. Whenever you are giving HRT, do not give only estrogen if uterus is still there. Only a post-hysterectomized patient, you can give only estrogen. Complete treatment of PCOD, avoid risk factors like obesity, lifestyle modification. OC pills reduces the risk by 40 to 50%. Tibolone reduces the risk. LNG-IUS is an effective, simple, against simple hyperplasia. Women of women on tamoxifen, periodic USG for endometrial thickness. Okay, she should undergo a periodic evaluation. Even if the endometrial thickness is increased, then you have to do a endometrial sampling for her. Okay, this also you please, I'll clear the slide. Please see this and make sure you remember all these things because this is commonly asked in your MCQs. Lastly, ending with the MCQs, a 55-year-old woman with heavy menstrual bleeding with delayed irregular periods came with consultation. Diabetic and hypertensive, most probable diagnosis. As we told, these all features are for a postmenopausal bleeding with diabetes and hypertension is a corpus cancer syndrome, and this will be mostly a endometrial CA. Next question, which diagnostic procedure is the gold standard for endometrial cancer? What is it? Hysteroscopy guided biopsy, isn't it? So this is what it is. Then next question will be, a 52-year-old postmenopausal woman with diffuse uterine bleeding has endometrial thickness of 8 mm on ultrasound. What is the next line? So postmenopausal bleeding with 8 mm ET. So if it is more than 4 mm, what you should do? You should do endometrial biopsy, isn't it? Progesterone therapy? No. Hysterectomy? No. Ultrasound for after 3 months? No. If it was less than 4 mm, you could have done. Endometrial biopsy is the treatment of choice. Next question. A postmenopausal bleeding is defined as any bleeding from genital tract after 6 months of menopause? No. Any bleeding from genital tract after 6 years of menopause? No. Any bleeding from genital tract after 1 year of menopause? Yes. So at least after 1 year, if she is having, after 1 year only, it is called as postmenopausal, isn't it? So after that, if she bleeds only, it is postmenopausal. So correct answer will be C. So here ends your INI-CET quick revision of postmenopausal bleeding and endometrial CA. I hope you've understood and it will help in your exams. All the best. Thank you.